All right, students, this is Dr. Weaver again. I wanted to go ahead and do a voiceover on um, the discussion regarding pain. This is a very important topic, especially for nursing. Um, and because of the fact that the pain experience is different depending on one's culture. For example, we all do not experience pain in the same manner. But anyway, it's such a very important part of your job that it really behooves you to really take note in how to manage your patient's pain. Otherwise, um, you will not be doing your patients much in the way of any justice, if you will. For example, sometimes we tend to think people are malingering, playing sick, or drug seeking, and so forth. And it can be that, but it is just really important to get a sound understanding of pain as it relates to patient care, so that you can individualize your approach to managing it, because it is an individualized approach. So without further ado, let me just go ahead and start to share my desktop. That's that. Sharing. All right. Actually, all right. So nursing care of patients in pain. Again, very important topic. Let me make sure everything is set. All right. So we are recording. All right. All right. Good. All right. So let's dig in. Take a look at the learning outcomes. So at the end of this discussion, this is what you ought to be able to do. You should be able to describe current definitions of pain. There's a couple of definitions that we will look for. There was a time where I thought when it came down to words and what have you, well, not only the English language, but just language in general. I always thought that there was just one definition for any and everything. But then I discovered, especially when I was working on my doctorate, we did what you call a concept analysis course. And essentially, what we discovered was that certain terms are defined in different ways, like critical thinking. One of the definitions of critical thinking is thinking about your thinking. Now, of course, that seems pretty simple, but there are other more sophisticated, ways of defining critical thinking. So we talk about describing the current definition of pain, and so we will look at that. Identify common myths and barriers to the effective management of pain. Differentiate among addiction, physical dependence, as well as tolerance. Explain current understanding about the basic physiology of the pain response, and we'll get into that shortly as well. Really interesting, actually, and I think I'll probably provide you with a YouTube video. It's a short video, less than 2 minutes, that can show you how pain actually occurs in the human body. Differentiate between the nociceptive and neuropathic type of pain. Perform a basic pain assessment, very important, especially for those who are not able to verbalize the fact that they are in pain. There are other different ways that we can do that. Describe the three classes of analgesics and their uses, and also identify commonly used pain medication treatment modalities or treatments and appropriate use. Um, Recognize appropriate use of non-pharmacologic pain management techniques, for example, massage or some music therapy, and what have you. All right, some of the main concepts that we will encounter as we go through this discussion is addiction, comfort, as well as safety, and definitely safety. All right. Now, take a look at this one definition by the International Association of the Study for the Study of Pain. They defined it as an unpleasant sensory and emotional experience associated with or resembling that associated with. It can be actual or it might be even potential tissue damage. And pain can be emotional. In our minds, typically we would probably think pain has to be, a physical, but it can also be emotional as well. Right. It essentially indicates that pain is a complex problem that is not just physical in nature or always the result of a tissue injury. Now, this is a very important definition of pain, and actually, it is actually the gold standard that we use to note that someone is in pain. And it says that pain is whatever the experiencing person says it is, existing whenever the experiencing person says it does. In other words, you cannot speak for that patient. All right. You can't say that patient is not in pain, that they are playing, they're malingering, they just want some drugs and so forth. Um, uh, I only know what I'm feeling, and no one can get in the mix of that. All right. So some key points about pain. Pain is a personal experience shaped by events over one's life course. The patient's self-report of pain is the what? Gold standard in pain assessment. All right. When the patient tells you that they are in pain, that's what we need to go by. Right. Pain can negatively affect a person physically, emotionally, socially, spiritually, and financially. All right. Now, let's talk about the types of pain, be that acute versus chronic. When it's acute pain, it generally lasts less than 3 months, but may last up to 6 months or longer, depending on the cause of the pain. The symptoms, they lessen over time, and so as time goes on, there's less and less pain due to healing. And then pain prompts an inflammatory response. That's all a part of inflammation is pain. Also, signs and symptoms are short term. They are objective and physical. For example, when people are in pain from a physiological perspective, it may cause an increase in heart rate or respiratory rate. It may cause an increase in their blood pressure. You may see facial grimacing. You can see it in their face, right? Letting you know that they are indeed in pain. On the flip side of that, chronic pain, it lasts longer than the anticipated time of healing, which is longer than 6 months. The signs and symptoms, they persist. They're not getting any better. They're not lessening over a time. Patients may not always appear to be in pain. Now, that's really the key because the body is able to adapt to pain, right? It's able to adapt. In patients with chronic pain, they may not appear to be in pain, but yet they really and truly are because the body has just adapted to it. It can cause an increase in depression or in negative behaviors in patients with dementia, autism, schizophrenia, and other psychiatric conditions. All right. Um, I think the takeaway here is do not think that the absence of physiological pain symptoms like the increased heart rate, blood pressure, respiratory rate, and so forth, do not think that the absence of those physiological symptoms means that the patient is not in pain. Again, the body does adapt. Right. Suffering. What is suffering? Essentially, feelings of continuous distress, often associated with chronic pain. I mean, you got to go through this same pain day in and day out, day in and day out. I mean, you can only imagine that it can cause a significant amount of suffering. It can cause emotional and spiritual distress, and may be relieved with belief that comfort can be achieved. So if they feel like they can achieve some relief, then the sufferings might be more diminished. All right. Now, spiritual coping may be a source of comfort. These patients may engage in religious practices such as prayer or meditation, which can bring about some relief. May be non-religious and include self-reflection activities or connecting socially with others to affirm meaning and that there's a purpose in a life. Right. Now, nurses can encourage patients with persistent pain to engage in spiritual practices that they may find meaning, and also with people who might bring them some joy. Those who are at risk of uncontrolled pain. So the body produces a stress response that causes harmful substances to be released from injured tissue. All right. Now, complications that can occur when pain is experienced. Um, essentially, so the body produces a stress response, as I mentioned, to pain that causes these substances from our tissues to be released. Now, reactions, some of those reactions would include things like the breakdown of tissue, increased metabolic rate, impaired immune function, and also negative emotions. In addition to that, pain can prevent the patient from participating in self-care activities such as walking, deep breathing, coughing, and what have you. Now, when you think about just that alone, the deep breathing and coughing, think about if a patient had surgery, a chest surgery, and it essentially it hurts for them to cough and to deep breathe. Um, pain may make the patient not want to cough and not want to turn or much less move at all. Right now, what this results in is because you're not moving, you these patients tend to retain pulmonary secretions, and it can develop into pneumonia. If the patient becomes less active, even return of bowel sounds function is going to be delayed. And these patients can actually develop what is called an ileus, an intestinal ileus. And what this is basically a disruption of normal propulsion of gastric activity. So, in other words, that peristalsis that we always talk about, um, it can disrupt a peristalsis. Now, when pain is well controlled, complications can be avoided. The complications that I just mentioned, people when the pain is controlled, they can deep breathe, they can cough, and they can get up and ambulate, and they can participate in physical therapy and so forth, and other related self-care activities. All right. And so this will speed discharge, of course, that we can control the pain. We can discharge these patients a whole lot sooner in order to allow them to participate in their life, if you will. Now, this is a very important one. Cultural considerations. One thing I always say to students is that we cannot Americanize everybody. All right. People come from different parts of the globe and to come live in this country, and you cannot acculturate everyone. And so, people do come with their own cultures and traditions and so forth. And we have to approach them in that way. There should be culturally specific and sensitive care that we provide. As far as the key areas of cultural expression, cultures express in language, how they communicate, how the family engage, spirituality, and also even their treatment preferences. They may like, non-Western type of medicine to be incorporated into their care. And we always want to assess each patient's pain experience. Don't just lump everybody in the same category. And also remember the ethical principles that you have probably had in the past, um, um, as far as ethics. Let's see. So who is responsible for pain management? All right. So the patient is the center, of course, of health of the healthcare team. Everything should essentially focus on what we do should focus on the needs of the patient. The entire healthcare team is responsible for pain management. Um, and there are some regulatory bodies that ensures that the hospitals are doing what they're supposed to do. And pain is one of those elements that these regulatory bodies assess to see if the hospitals are addressing their patients' pain appropriately. It's kind of weird when you think about it because why would an agency have to be the regulator of such as that. That should be a regular or typical, usual nursing task, if you will. But some of those organizations would be, for example, the Joint Commission or TJC, CMS or Centers for uh, Centers for Medicare and Medicaid Services. There's also some state licensing bodies that are involved in this effort, along with ARAC or Agency for Healthcare Research and Quality. Folks, give me just a moment. All right. Yeah. So I had drank some Kool-Aid, which is mostly water, but kind of makes me have to go to the bathroom. I have good kidneys, let me tell you. All right, so let's take a look at the what we refer to as opioid addiction. There is what we call tolerance, physical dependence, addiction, psychological dependence, and also pseudo addiction. And I'll go. Let me just go over a couple of them. Tolerance is a normal biological adaptation to long-term use of a drug. The drug becomes less effective, and the patient needs a larger dose to provide the same level of pain relief. Right. So these patients are essentially on these medications for quite a long time, and they build up this tolerance to the degree that it no longer is effective, and so we have to increase the dose in order to provide better relief. And so we really need to be aware of this. We need to ask the patient, what medications are you on? How long have you been taking it? Has the dose changed at all? And so forth. They might say, been on it for 5 years, and I've only had one increase in the dose. Maybe hard for us to find out, but those are things that we need to be thinking about. As far as physical dependence, is a normal physiological, it's more physical response that most people experience after a week or more of continuous opioid use. So you're on these opioids for a good week or more, and you become dependent on these drugs. Now, if an opioid is discontinued abruptly, right, very quickly, and an opioid antagonist such as Narcan, is to be administered. And if this is the case, this patient will experience what we call withdrawal syndrome. All right. Narcan is just it reverses the effects of opioids. Essentially, we have these receptors that opioids attach to, and that's what brings about the relief. But with the Narcan being an antagonist type of medication, it occupies, it covers those receptors, and so the opioids cannot, stimulate or attach themselves to those receptors, and so the patient has less relief of pain, if you will, or even the high that they get. It's kind of like when we catch these patients who have OD'd on heroin, and the paramedics go out and they or the law enforcement or whoever, and they give them Narcan. Basically, the Narcan being an antagonist, not an agonist, but antagonist. It occupies those receptors, and that high that they had will reverse. But it does allow them to breathe again because the opioids is what causes the respiratory depression. Now, when patients do experience withdrawal symptoms, it looks like basically headaches, the sweating, they have a lot of tearing, running nose. Seems to almost describe me. Anyway, restlessness, irritability, tremors, dilated pupils, sleepiness, nausea, vomiting, as well as diarrhea. Now, these symptoms can be prevented by decreasing the dose slowly over several days rather than just suddenly stopping the medication. All right. And go ahead and take a look at the other two that I provided for you. Um, and be able to define these. Now, here, I am going to provide, let me see if I can do it now. I'm going to provide you guys with YouTube video on um, how pain is transmitted. Oftentimes we think that you touch something hot and automatically that you have pain or you experience pain or discomfort. But the process is a little more complex than that. And so these different terms here, transduction, transmission, perception, and modulation, is actually what is happening when someone experiences pain. So basically, there are four stages. So what happens is in transduction, this is the first step where the body turns a painful stimulus, like if they were to get cut or they touch something very hot. That's the painful stimulus, right? And the body will turn that painful stimulus into a signal. All right. So think of it as the body's way of detecting damage and creating a message that is going to be eventually sent to the brain. Because remember, the brain has to interpret this at some point. At this point, as far as transduction, the brain has yet to receive the information. And it happens fairly quickly, but we're kind of going through it step by step so you can get an idea of what is actually happening in the transmission of pain. Now, the transmission piece of this, once the body makes the pain signal, all right, it needs to be sent to the brain. This happens through our nerves, right? It's like a chain of nerves. So the signal travels along the nerves like a message that is being passed down a line. All right, it's well on its way to the brain at some point because the brain is going to have to process that pain of that information. As far as perception is concerned, this is when the brain actually feels the pain. It's where we become consciously aware of the pain. Right. See, now the brain is interpreting this data, these nerve impulses that occurred from this pain stimulus. The brain processes the signal and tells us, "Hey, this hurts. This is painful." So it's the part where we experience the sensation itself. And then, of course, or lastly, modulation. The body tries to change or control the pain at this stage. Modulation. It's like the body's natural way of adjusting the pain level, all right, either by reducing it when it releases endorphins or increasing if it is required. Right. And think about it's like turning a radio volume up or down on a radio. So your body is essentially reacting to this pain in some kind of way. Take a look at the video. It's about, as I said, less than 2 minutes long, so shouldn't take you too long to get through. Let's see. If you wanted to. All right, now look at the neurotransmitters. All right, these are the neurotransmitters. Chemical neurotransmitters are released from our tissue that is damaged. And those chemical transmitters or neurotransmitters are the prostaglandins, the bradykinin, the serotonin, substance P, and endorphins, i.e., enkephalins. Um, all right. All right. And now pain transmission can be or is considered nociceptive and also neuropathic. Um, Now, nociception or nociceptive refers to the body's normal reaction to noxious stimuli, such as tissue damage. Somebody gets cut. With the release of pain producing substances that we just mentioned. Now, nociceptive pain may be somatic or visceral. So, just think about the organs inside of our bodies. Somatic pain is localized in the muscles or bones. Patients can often point to the exact location of the pain and would describe it as throbbing or aching. When you think about cancer patients, they may experience somatic pain when cancer spreads to the bone or a tumor invades some soft tissue. Now, visceral pain or organ pain is not well localized. It's just really difficult to pinpoint if someone's organs for example, cancer has invaded one of the organs. It's hard to localize which organ that might be. It's just not well localized. And most patients would describe it as either cramping or pressure type of feeling. Uh, Bowel obstructions and tumors in the lungs can cause visceral pain type of symptoms. Now, pain may also be felt in parts of the body away from the pain source, such as low back or flank pain that often accompanies a bladder infection. So the problem is in the bladder, but you may feel some of the pain in the lower back or the flank area. We call that referred pain. It's not, you don't feel the pain directly in the organ where the problem is, but it, I guess some people may refer to it as a kind of radiation, a radiation, a pain, or the pain radiates to other parts of the body. But we refer to this as referred pain. Now, neuropathic pain is associated with injury to either the peripheral or the central nervous system. Now, unlike the nociceptive pain, neuropathic pain is poorly localized and may involve other areas along the nerve pathway. So it takes a different pathway than the nociceptive type of a pain. The neuropathic pain is common in cancer patients following, for example, chemotherapy and radiation treatment. It also occurs in patients who have fibromyalgia, diabetes neuropathy, as well as shingles. The pain is often described as numbing, tingling, sharp shooting, as well as shock-like. And these are the types of pains, that is the neuropathic pain, that they treat with drugs like when we treat seizures and also patients with psych disorders like Elavil or Cymbalta, Tegretol being a seizure medication. I think even Dilantin they may use as well to treat neuropathic pain. It's because the pain just takes a different pathway, and these medications tend to be effective in managing that type of pain. And this is just the referred pain. The pain can be uh, coming from, or rather, the patient can have an issue with one part of the body, an organ, if you will, but the pain will be felt elsewhere. Again, we refer to it as referred pain. For example, when someone has, I believe it's pancreatic cancer, right? So you guys know that the pancreas is in the abdominal cavity. And these patients, if I remember correctly, they may have a pain in the shoulders, I believe. It's like a referred type of pain. There's a theory behind that, but I won't get into it right now. So pain treatment, you have analgesics, opioids, non-opioids, adjuvant drugs, opioid antagonists, as well as other treatments. Now, medications that relieve pain, of course, are called analgesics. Analgesics make up a large piece of the pain management puzzle, if you will. They encompass three main classes of medications. Again, you have your opioids, non-opioids, and adjuvants. Your opioids, they bind to opioid receptors in the brain, the spinal cord, and other areas of the body. And what this does is it inhibits the perception of pain. Because if you didn't give these drugs, then that signal, those impulses are going to tell the body that you're in pain. But if I can block those receptors, then the brain won't be able to interpret the experience of pain. Now, opioids include your NSAIDs, your acetaminophen or Tylenol. Your adjuncts are different from your opioid and non-opioids in that they include categories of medications that were originally approved by the FDA for purposes other than pain relief. This is what I was talking about. The medications we use to treat depression, like Cymbalta, we might use it for neuropathic type of pain. Now, some patients may require a combination. You may see a patient on an opioid, they may be on an adjuvant a medication as well as a non-opioid drug, such as an NSAID, to effectively manage the pain. So essentially, they seem to be trying to tackle it in different ways, right? The pain may come about a certain way, and we're trying to tackle it every way possible, in other words. Whatever pathway the pain is taking, we're going to try to cover that, in other words. Uh, let's see. Placebos. Administer inactive substances for analgesics. In other words, these pain medications usually become active substances or substances, but placebos do not. So the patient essentially thinks they are receiving analgesics. Not justified in the treatment of pain. So the patient must actually sign a consent to be, let's say if this was a study, if you will, it's unethical to give a patient a placebo. Only used in research with informed consent, as I just mentioned. All right. Um, as I said, this is unethical and inappropriate unless the patient has given you a written consent. You just can't, for example, the patient thinks they're getting IV morphine, but yet you're giving them IV normal saline. You can't do that. All right. That is unethical. May cost you your license as well. Some of the various routes that we need to think about as far as pain medications, we can give it by mouth. We can give it rectally. We can also give it as an inhalation. We can place a patch on the skin, transdermal, intramuscular, right? IV. The patient controlled analgesia, or what we call a PCA pump. This is some technology that has been out for many, many years that the patient essentially controls their own pain. The doctor writes the order about how much they can give, and the patient presses the button when they feel they need it. Now, let me tell you something real quickly about this. Um, Sometimes, let's say if the patient has a morphine PCA pump, while the patient is sleeping, the family member is in the room, and they might feel that, oh, my loved one is in a lot of pain, and they just keep pressing that button for the patient. Well, that has resulted in a drug overdose because you're drug overdosing that patient. Remember, the PCA is essentially for those, for patients who perceive their own pain and know how much they need. You're just going to have somebody in a who is not you, basically, and just keep pushing that button because that can lead to some serious issues. There's also subcutaneous as well as intra spinal, like epidural or something like that. Take a look at the non-pharmacological therapies. We have the cognitive behavioral. We can educate. We can employ some relaxation techniques, imagery, like the imagination, if you will, distraction, like music. And whatnot, and also biofeedback, where they the patient is controlling their pain by a biofeedback, something that we do with our mind, if you will. Physical agents that we use sometimes is heat and cold. massage, exercise, immobilization, not moving the extremity, and also TENS, transcutaneous electrical nerve stimulation, especially for issues such as low back pain. Let's see. Let's see. And this is a good pain assessment questions that you can ask your patient. If they use the acronym, what's up? Where's the pain? How does the pain feel? What are the aggravating and alleviating factors? What makes it better? What makes it worse? What aggravates it? The timing is important. Um, Severity on a scale of 1 to 10, or 0 to 10. What is your pain level? Well, my pain level is a 2. Well, they may not need any pain medications, but then someone comes and says it's 8 or 9. Well, then we have to think about what we need to do. Other data, of course, relevant data, and also the patient's perception would be important. These are the different pain scales that we use. 0 is no pain, but the worst pain would be a 10, and we considered it mild, moderate to severe. Um, these are faces pain scale when someone cannot verbalize, but we can tell them to point to either of these images to let us know what their pain level is. Right. So we basically show it to them, and we let them tell us which number more aligns with their experience. With this one, pain assessment in advanced dementia patients. So basically, this is the behavior here in the vertical line, first line or column. Um, and let's say this one here, for example, would be 0 would be considered normal. Occasional labored breathing, if you see them having labored breathing, or short periods of hyperventilation, you give them a 1. Or if it's noisy labored breathing, long periods of hyperventilation, or Chine-Stokes respirations, that's a type of respirations. If it's that, of course, we give a 2. And so any one of these that we choose, we assign the numerical value here, and then we total it. And of course, it will let us know um, whether or not the patient's pain is mild, severe, and what have you. All right. This is one that we use for level of sedation, um, and so that we don't overdose a patient. And so it can be all the way from a normal sleep all the way to unable to arouse. You take your knuckles and you bury it into the chest to try to get them to respond, and they just don't respond at all. But this patient is likely over sedated. Now, if they're occasionally drowsy, then we know that we're pretty safe. But again, as we go down the scale, it gets kind of very dicey and whatnot. Uh, Patient education. Where did I see that? All right. As far as patient education is concerned, we need to think about the analgesic side effects such as fatigue, also constipation. We need to make sure that the patient is eating a high fiber diet, drinking fluids. And we know that NSAIDs as well as opioids can lead to constipation. We also must think about the adverse effects. So we need to monitor the patient's vital signs. What does their blood pressure, respiratory rate looks like? Is it declining as a result of these medications? And also we need to monitor the total acetaminophen doses. There's so much that you're supposed to get within a 24-hour period. I believe it might be somewhere around 2,400 milligrams, if I'm not mistaken. And well, Yeah, it's somewhere along those lines. If these patients take more of the acetaminophen or Tylenol, it can destroy their liver. I knew one time a lady, she was in so much pain to the point that she just kept popping those Tylenols, and she went into full liver failure. I think they call it fulminant liver failure. I believe she needed a liver transplant as a result. That's why we have to educate these patients. They don't know, even though it may seem like they should know, they don't. Pain education. So dose, frequency, and duration. So take the medication on a schedule with chronic pain to improve mobility and function. This is being taken more routinely instead of waiting until you're in pain. Basically, these patients are always in pain, so they should be on a rather um, um, more frequent schedule in order to control the pain so that they can have a better quality of life. As far as interactions, be careful about pain medications and muscle relaxants. It can certainly decrease the respiratory drive, cause respiratory failure, and do not mix drugs or alcohol with pain medications. We know that this happens quite often. All pain medications should be kept out of reach of children. That's a given. Opioids should be locked away or at least not easily accessed by other members of the household or visitors, because we got some visitors who are pretty shifty, right? Ensure proper disposal when discontinued. You don't want them just lying around. And folks, that seems to be it. So that didn't last too long, uh, which I'm very happy for that. All right, so let me stop sharing. So this one was about 48 minutes as well, so not too bad. You can speed it up because I'm going to have it on a YouTube platform. Anyway, I appreciate you, and let me know what you think.